Hello, everyone. I am Chris Marchack. I am your host tonight on Clinical Chats, episode 51, where we hope to enlighten, entertain, and educate you on all topics in the field of dentistry. Please be aware that we are unable to see or hear you, but we encourage your participation and are happy to address any questions you may have. Simply click on the question on the Q&A button located on the right-hand side of your screen. We will make every effort to answer them during the webinar. Rather than having a designated Q&A time, we aim to integrate your questions and comments throughout the session to maintain an engaging and interactive experience. Please feel free to submit your questions whenever they arise. The CE credit will be sent to the email address you provided within 48 hours, and this session will be accessible on demand in the coming days. Now, on with our program. For those of you who have joined us before, you will all know my two dear friends and co-hosts, Dr. Frank Vidjak, prosthodontist in Beverly Hills, and Dr. Brian Goodacre, prosthodontist in Upland, California, and the Director of Clinical Technologies from Noble Biocare. Hey, Frank. Hey, Brian. How you both doing?
Doing great, Chris. Glad to be here.
Doing awesome. Good to be on as always.
Brian, where are you today?
I'm in Austin, Texas. So.
Well, we get to travel via wherever you are on all these programs. What's going on in Austin?
We're here for the AAP, the perio, the annual American Academy of Periodontology meeting. So should be a fun meeting.
Fantastic. Hey, we got a really interesting topic today. For this episode, I would like to discuss about something that's really not talked about a lot these days, or anything in the literature or any clinicians or lectures. I want to discuss about your post-treatment protocols for the fixed complete denture patients. You know, yesterday, if we can have my slides there, yesterday, I just inserted a patient's treatment, and as I placed in the treatment here, this is the inserted fixed complete denture, the zirconia fixed complete denture. And what we have here, the question I have is, what do you do after the definitive treatment prosthesis is inserted to place? Whether it's in zirconia, whether it's a metal and resin type prosthesis, whatever the fixed complete denture is, what is your protocols? How do you maintain these patients? What do you do on your recalls, your yearly exams? When do you take x-rays? But before we discuss that, let's start our chat and our poll for this. What do you do in our audience in your yearly examination of a full arch fixed prosthesis for patient? Please check as many as applies. Do you do routinely periodontal probings around the implants? Do you remove the prosthesis to check each implant? Are you doing periapical radiographs of each implant? Or are you doing panoramic radiographs? How many of you check the occlusion? So as we wait for this poll, Brian, Frank, it's interesting because there was an article by Bidra in 2016 that was a systematic review of the recall regimen and maintenance regimen for patients with implant-borne restorations. One of the first statements that was made in that manuscript says that there is minimal evidence related to this. So what are your thoughts? What do you do after you deliver a prosthesis like that? Brian, what do you do?
Well, for me, I think the first thing that I think is important we talk about, that's I think we probably is on all of our minds, is patients that undergo this type of treatment, we always have to think there's a reason they lost their teeth, and it's traditionally not because they were maybe the best recall or hygiene patients in the world. So I think that's something that has to factor in. But for me, I'm always looking at, just like when you do have teeth, we could decide, is that patient on a 3-month recall, 6-month, whatever that case may be. We do make that kind of on a case by case basis. So for me, what I tend to do is, after I place the prosthesis, I'll see them for the checks that we need to, more like immediate after we place that. But for me, it's traditionally in a 4 to 6 month time frame. I have them come back and I do my first check. And what I do is I clean it myself, and I traditionally, like to take gauze and cut into like a little strip and pass it through. And what I'm doing at this point is just trying to see what I get to come out. So if I'm getting a lot of food and things coming out, then that's telling me that at the 1 year or the next 4-month mark, depending on the interval that I'm seeing them, I'm going to, at that point, decide whether I take the prosthesis out and clean it and put it back, versus just leave it in and keep cleaning it myself, or the hygienist cleaning it, depending on how well they are cleaning. So I think that, to me, is always patient by patient is how I decide. And some patients do a great job of keeping things clean and some do not. And so that dictates whether or not I'm going to take it out, for example, which I prefer not to if I can, in all honesty, because I think if you do that all the time, right, you're wearing and tearing, either components or disturbing, tissue. But it just depends on how well they keep it clean. So that's my thought.
We'll have more to talk about with that, Brian. How about you, Frank?
Well, Chris, you mentioned, about the literature, and
Yeah.
it is amazingly sparse when it comes to this. And it's actually concerning to me that it is so. Even the articles that were reviewed in Bidra's, series, and part 1, 2, if you at all, because there's a lot of authors in that. I think somewhere around 11 contributed to that manuscript. But the bottom line is, if someone wants to go look at the literature and look for a recipe, you're not going to find it. There is nothing there that will help someone in clinical practice to say, okay, if you have this type of restoration, this is the recall protocol minimum, some kind of guideline. I mean, heck, we can't even get a real agreement on how often should you get radiographs made for a patient. ADA is constantly, it's like, it's like swaying like a flag in the breeze. Okay, because we like to be black and white, right? In the health professions, wouldn't it be great if it was always black and white? But how often does clinical judgment come in? Well, I'm going to back it up now, knowing that we really don't have much of a foundation to stand on, except what we did gain from that, and it gave somebody food for thought. So in those articles, you have 3 factors that come into play, really, right? It's the kind of restoration that was placed for the patient, right, as part of your factor to consider. What was what type of treatment? Number 2, what kind of home care regimen did you give the patient? Did you give them any kind of chemical, I mean, in that paper, we know we can't use triclosan anymore. Okay, so, fluoride, different types, chlorhexidine, rinses. But even then, it's confusing. How long would you give somebody chlorhexidine rinse, aside from the staining? Okay, because technically it's an antibiotic. How long do you want them to stay on it? Okay, so we have those concerns to worry about. But okay, you tell them brush, floss, water pick, whatever your regimen happens to be. That's factor number 2. Then factor number 3, which is pretty clear cut. It seems pretty well established in the literature, perio literature. Professional care makes a difference. So that means compliance of the patient to come back. How well do we know these patients when they first come in? I mean, I met my wife. I felt something special when I met her, but I didn't go the next day and ask her, "Let's get married." Every relationship's different. Some people go for years, 10 years, 15, and they finally decide to tie the knot. Some people meet and quickly they know. Okay, that's the way our patients are. But you don't know that. So what can we do? And we've spoken about this before, right? We're
Yes.
concerned about the last chat. We chatted about
Yes.
fracture. How do you plan against, a fracture? What can you do? Success of
That's
treatment.
interesting.
You can have the best treatment on this planet and be a blazing failure because, as Alex Coper used to say, we didn't meet the mind.
Yep.
Okay,
Yep.
we missed the mark. So to get to the point of your question is, I'm going to do everything possible to find out if this patient is a candidate for whatever kind of implant treatment, because they may not be a candidate. They may be their worst enemy. And we
Oh,
need
Frank,
to understand that.
you're talking about really evaluating the patient in regards to yearly exams, all before you even start treating the patient.
I will be looking at that patient because, Brian, you're absolutely right. People don't electively, well, I had one recently, but that's not for discussion right now. I walked the patient, but he managed to go to a different part of the world where they removed all his remaining dentition because he thinks, like patient said, well, if you take all my teeth out, give me a denture, I won't have problems anymore. Well, now we've upped the ante a little bit. If I have implants, I won't have any more problems. So I guess apparently in the States, he couldn't find anybody, so he ended up overseas. Different chat. But having said that, it's getting a feel for the patient. So I find a manner to learn about them, whether they're going to be compliant enough. Am I going to be able to succeed to make contact with the mind of this patient so that they will follow protocols? So, okay, let's say they look like they're going to be compliant. Well, then you try to find steps to see whether they're going to even tolerate a process, a change.
Yep.
I know we're talking about hygiene. So where do I really learn about that? This is where I really spend time in the provisional phase. So when it comes to designing, we focus a lot on aesthetics. We want everything to look good, right? Who wants something that looks ugly? Well, what if? There's the big what if. Should we or could we make a little deviation of what looks wonderful when you put the retractors in and make a compromise to help the patient maintain the restoration more easily?
Yeah.
Okay? Because a lot of times it's us. We limit the access. So I'll spend time in the provisional and I'll modify it. I've done this just recently, a couple of weeks ago. I had to remove the restoration, open some areas up. And the patient was understanding. So that's what I'll do before the final. And that helps me to develop the regimen post-treatment.
So let's look at what the polls came back as here, Frank and Brian. 29% do periodontal probings. 12% remove the prosthesis to check each implant. 23% do periapical radiographs. And 11% do panoramic radiographs. And 25% check the occlusion. Interesting. I want to break this up a little bit because I want to break it into a different type of chat. Let's break it up into maybe 3 parts here. What do you do right after the insertion? What does the hygiene appointment look like? What does your yearly examination protocols? What do you do at those protocols? And we kind of touch a little bit about each one of them. And then some things about home instructions. And Frank, you're starting to talk a little bit about that already. Brian, what are your thoughts about your delivery protocols? What are you doing at that time?
Yeah, so once the prosthesis is in, and again, we can have separate discussions on all that, but when it comes to the hygiene part, I think one thing we commonly do is we're so excited to place that in the mouth. Patient gets excited when they see it. Very kind of, it's a great moment, but we at that point kind of say, oh, great, wash your hands and out the door. But we have to take the time to show them how to clean. And that's something where, it's important. I spend a lot of time where we actually, patients holding a mirror, I'm holding, different types of aids that you can use to clean, and actually showing the patient how to do that, and then having them actually demonstrate that they can do it, so that it's not okay, brush every day, they get home and then they struggle to be able to even do that. So I think that's a big part of the day of placement, is actually taking the time to go through, answer their questions, but letting them see how you do it, as well as having them demonstrate that they actually can. Because you may find that one of the, you may like super floss as an example, but they struggle with that. So you may need to decide to do something else. And that's important to see. Yeah.
Frank, any comments?
Well, Brian, you're right. Education is everything, coming from us, not from a video, but right there while the patient is with us. Given the idea, okay, let's assume that the treatment as planned continues forward to the final restoration. So you have the provisional. That's why I put so much importance on the provisional. The thought of a final restoration from the get-go, to me, I can't even imagine doing that. I can trim back provisional material. I can add to it. I can do all kinds of things to it. Once it's in zirconia or zirconia cemented over a bar, anything like that, it's a disaster to go back and modify.
That's a disaster.
So
Absolutely.
The final restoration should pretty much be a clone of the provisional. So I use the measure of how they manage to maintain the provisional. And that's where, when you saw in that poll was great, Chris, because the factor of removing the restoration, I'll remove the provisional restoration, and then I'll show the intaglio surface to the patient, and they jump back. They go, yeah. Wow, what is all that? I said that. If you were able to look at them close enough, they're creepy crawlers. I don't think you'd want them on your bedroom wall. Okay. Yeah. So why do you want them here?
Yeah.
Okay. Do you know that these little bugs that are sitting here are the same ones, for the most part, the ones that killed your teeth? Yeah. Do you want them to kill your implants? So a lot of times I don't think that we explain during our hygiene instruction and, checks, just how important this is, this factor of the maintenance phase of treatment. So yeah, I'll remove the provisional, but I rarely remove the final prosthesis, because you should be having access for cleaning. It should be predictable by the time you get to that point.
Completely in agreement with you. That provisional restoration is key, and one of the key points in the restoration, to get the patients to understand how to clean around them, show the patients, and copy that in the definitive restoration. I am 100% in agreement with you with that, Frank, because you don't want to be taking these things off all the time. There's just, especially that definitive restoration. The provisional, absolutely, but the definitive, I don't want that off.
I don't know about you. I don't know about you, but even taking the provisional off, God bless gloves, but they're like a slingshot. Don't think for a second I haven't hooked up on a glove and it flies on the patient's chest, and I'm thinking, why would I, even if I had the zirconia, the final restoration in my hands, simply going to the sink, do you know how much paper towel I put in the sink for in case it drops? It's like I have a pillow there. People are so lackadaisical thinking about this.
So we have a few questions here. One is from Dr. Kitajima, and I hope I pronunciate your name correctly. If I'm not, I apologize. Can you use a bioblaster that uses aluminum trioxide to remove the biofilm? To be quite honest, I'm not familiar with it.
Aluminum oxide?
Aluminum trioxide is the statement here.
But it's still an abrasive, right?
I think so too.
Yeah.
I kind of question that. I wouldn't necessarily want
I would
that.
say, I think the other part of it would be you're even regardless of the roughening the surface. The other part is it's only going to actually clean what it can touch. So if wherever it's sealed against the tissue, it's not going to go between the tissue. So I don't think it would be quite as effective. Plus, I'd be worried about roughening, a polished surface.
I mean, if somebody were thinking about it, how in hygiene they'll use baking soda, air braid, get stains off. But you're right, it's angle of view where the tip can get in. And I'd still be worried, even if it was baking soda.
I'd be worried
anything
too.
Being shot in can abrade tissue. Forget if it has minimal effect on the metal.
Absolutely,
whatever contact.
Absolutely. Later on in the program, just to kind of give you a teaser to answer some of those questions, I'm going to quote some of the things that your predecessor, Brian, Dr. Rick Sullivan, and Yvonne Fartan have done in some of their work and some of that discussions. Frank, we have a good friend here, and we saw our wonderful friend Brian, Dr. John Tukey. He has a question here. Great to see you, John. I'll give a wave out and a shout out to you. Is there any non-destructive testing available for full zirconia restoration, such as ultrasonics or X-rays like aerospace parts, to prevent failures before they happen? Interesting question.
That's
Frank.
a darn good question.
Yeah.
I guess, for if it were metal, like John would know, you can flux, you can run a magnetic field through it, magnaflux it, but that's not going to help us much on zirconia, right?
No.
I would think, and John's very aware of this as well, the best we can go is by visual. And as we do with teeth, you see the problem with any kind of ceramic, it starts out with micro cracks. So how well are we going to be able to see micro cracks? And does every micro crack lead to a failure? And if you saw a micro crack, what do you do about it? Yeah. So I guess my answer to John would be, even if it was like days of old and you did metal ceramic with feldspathic on the framework and you saw a crack happening, as hard as it would be to decontaminate that restoration and dehydrate it so you just don't explode all the veneering ceramic off, it'd be so risky because of the magnitude, the possibility of a failure in the process of trying to refuse it. But even if you did that, okay, you could refuse that, but we know we can't heat it high enough to zirconia to refuse anything.
Yeah.
Right? So we have a limitation. So it's almost like you have the knowledge, what are you going to do about it? That's my thought. And it doesn't mean I'm right, but that's what I'm thinking. So you see it. Maybe if you saw it coming, like an earthquake alert, we could leave town, we could be proactive. That's great. And if we saw a crack on a restoration, we could warn the patient, it's imminent, this may go. But what do you think they're going to tell you? Well, how am I supposed to, now that I know a crack is there, now I'm really nervous. What am I going to do? What are you going to do? You're going to go and replace it because you don't know if, in fact, it may be a micro crack, but you don't know when it got there.
That was great talk and discussion with our last clinical chats last month.
So I'm concerned about it, but just like when I transilluminate for a tooth, it's for me to know what's there and try to use that information as part of the plan of whatever we're doing, whether it's indicated for a crown or if it's a tangential type, maybe it's not a good candidate for ceramic bonded onlay or something like that, right? It can help you with that. But once the treatment's done, the restoration is there. If there was a modality to fix it without remaking it, I would be the first one to jump on it. And doesn't mean it's not out there. I don't know. If there is a methodology out there, I'm just haven't heard about it, but I'd love to know if it does.
Brian, we have one more question out here already.
Sweet.
And this question is, which is really very apropos with exactly what we're talking about here. How long do you let a patient use a provisional before moving to a permanent prosthesis or definitive prosthesis?
I mean, the easy answer is it's at least 4 months, right? If you're depending on, so you at least got that. But then if you're
immediate load.
Yeah. So if you're doing the immediate load part, right? So, which again, that's quite common. So, but then the question becomes if you're going to make changes, which absolutely, I do that all the time. And you then are recontouring things, then you have to just give it time. But I wish I don't have like some magic number of how long that is, but I think you can find out pretty quick. If you have a couple weeks of them wearing something, you're going to know if they're, if you think about it, you're eating multiple times a day. If you're not cleaning it, it's going to be pretty apparent. So, or you're not able to, or you have an area that's not the right contour. So I think once you make a change, at least a couple weeks in the mouth with them trying to clean, then that gives you a pretty good idea. But, they're wearing it for quite a while.
I actually have them after they're in an immediately prosthesis, have the patients see the hygienist and work with the hygienist, because I look at our hygienists as coaches, coaching them how to work around the prosthesis and at the provisional restorations. And I actually have them start working with them after 2.5 months.
Yeah, that's good.
So we have some initial integration and start working at that time. Frank, you want any comments on that?
Obviously it's teamwork. It
is.
It's no one's an island in this, because technically we're expecting. Now that's always my hope. It bugs the heck out of me when you complete the active treatment, you get to the final restoration and the patient disappears. They're gone, right? Because they figure they're done with you. And it's troubling. But when it comes to evaluating them while you have them, that's why I put so much emphasis on what they do in the provisional phase, because I'm thinking they look like they're going to be compliant, but when it's all said and done, you never know what's going to happen. So I'll do the simple thing. I love Superfloss, and I have no interest in the company whatsoever, albeit I don't get a penny. But why do I love it? Because it's spongy. It picks up a lot of garbage. And my test with them is, I'm sliding this in. Are you ready for me to put this under that restoration? Because your future right now, how we move forward, is dependent on it. And it's amazing how they know they can get busted, because there's no hiding, right? Because the evidence will be there. And I'm always, when I see it come out pretty darn clean, no one's perfect. But when it comes out pretty darn clean, I congratulate them, because I'm happy for them, because they have the chance of getting a return on their investment in money and time, because they're showing proof that they can maintain this. Yeah. So my first jolt is, if it is immediate load, like you said, Brian, you have some time to kill, okay? And you can test them in between. And then when you take it off for the first time is when I show them, okay, this is what you didn't get.
Yeah.
And then if I see they need improvement and recontouring, whatever gets incorporated in there, until they pass that Superfloss test, I keep them that way. I said, when do you want to get finished? Okay. And I find if it's contour, if they tell me, look, I'm having a hard time getting it in between here, even if I use a floss threader, it's hard for me to get anything underneath. Well, then it falls on me. What can I do to help them? Okay. And once we reach that, then I feel good, because the idea of us probing, doing perio probing under these restorations, the way we used to do it, like Curtis. Remember Curtis Jansen?
Yes.
The apple on a stick, because there used to be that transmucosal element.
Yes.
Yeah, there's plenty of room. You could drive a car underneath that space. And if a person couldn't maintain that, we really had problems, right? But now we don't give that much space. Patients
Yeah.
won't accept that.
Like this,
So
like the case that I showed. Very
exactly
little.
right. Exactly right. So I mean, really,
So
they're being challenged. They're being
so you
challenged.
bring up a name from the past. We have somebody else who's asking a question here, and I think it's the same person. It's Dr. Steve Lewis.
Hi, Steve. Oh,
His question is, do you do anything special to the temporary to help contour the tissue so that the final adapts to the tissue without any concave areas?
well, go ahead. Who wants to go first? Go.
Brian?
I mean, for me, again, if you're doing a conversion, immediate load, right, you're going to get some changes in the soft tissue. So, that's going to be something. So then when you go back and recontour or add material, you can do some. But again, most of the time you're looking for this, very convex shape that's making contact. So I don't personally, with, again, different prostheses, we have to think about, if you're talking the traditional where the final is going to have pink and white as part of it, then you're going to touch the tissue kind of in this convex shape. But if you're talking about what they, FP1, where it's the final restoration is the size of a regular tooth, then you have to shape, the soft tissue like ovate pontics kind of, and that's a whole different dynamic. So I think it depends on the type of prosthesis. But for a traditional, like we say FP3, I don't do that much of like shaping the tissue personally.
I actually just try to keep everything in an ovate style. Like, for instance, what you see here, or this patient that I completed, is that it's all in a convex dimension throughout, so that it's an easier compression into the soft tissue and developing that all through the provisional. So I'll take off the provisional after that immediate load prosthesis and readapt that cavo surface. And then I actually make an index of that cavo surface so that I can have our ceramics mill out through Procera exactly in that cavo surface design. That's what we do. So, any thoughts, Frank?
Yeah, I think Steve brings out an important factor, because again, we talk about access for maintenance, right? Cleaning, and yet we have to have design for strength, to maintain its physical integrity, aesthetics, right?
Yep.
And what you both said, it's so situationally dependent, because in your mandibular anterior area, typically how wide are the ridges there compared to a maxillary anterior? They're very different animals, and
Absolutely.
depending on the residual ridge, what kind of form do you have? That's why in the planning stages, this is what's great about digital, right? And you can work with the Procera and the software. You can design your restoration, right? You have the clinical scan, superimpose it over the CBCT scan, evaluate your contour so you know if you're going to be going toward an ovate pontic. There are times when I've gone like a traditional tooth supported FDP. It may be a modified ridge lap type design, because I've had anterior ridges that are so narrow, it'd be very hard without having extreme directional change to try to do an ovate and ovate pontic. You might be able to develop somewhat of an ovate pontic, like you hear from Harel Simon. It kind of sets laterally more than vertically.
A horizontal ovate pontic that he describes.
Yeah. So we have to be open to these thoughts in the initial design. And that's why I go back to what I said in the beginning. We should not only be designing for aesthetics, but immediately designing for hygiene.
Yeah, completely agree.
From the get-go.
Yeah. We've got a lot of other questions. This must be an exciting topic because we've got so many questions.
Yeah.
What are your thoughts regarding it? And there's been multiple questions about this regarding the use of water picks or any other these types of devices as part of the regular regimen after using Superfloss.
Yeah.
Frank, you're the Superfloss king here, so.
Well, okay. I don't play basketball, but I'll dribble a little bit, okay, before taking the shot. All right. Well, it so depends on the circumstance. We have to evaluate really well the risk factors of using a pressurized system. And I haven't seen any clinical evidence or anything in the literature. So please add in there, because God knows I came close to reading everything that's out there. Okay. But I always get concerned, and I love any type of stream, any type of device that shoots a stream out, because it's a great way of delivering chlorhexidine. It's a great way of delivering, sodium bicarbonate rinses. It's a great modality, even diluted chlorine, bleach. It's a great way of shooting
modality.
When you can't count on somebody to really rinse or something, but be willing to get that stream around. So I do really appreciate them. On the other hand,
I used to like the water flossers, those water flossers that are not available anymore. But yeah, same kind of thing.
Yeah, so same idea, but where's my concern come up? Okay, let's take a palatal surface. And it doesn't have to be a complete arch restoration. I have plenty of people with partial, restorations.
Yeah.
And did you ever notice how sometimes in a maxillary anterior region, rugae get in the way? They're butting up right against the palatal, prosthesis.
Absolutely.
And I go in there on a clinical exam, and it's easy for me with a perio probe or an explorer. I tease that tissue back. It's not, there's those grooves. They just doesn't lie up there nice, close, and personal. So what do I get concerned about? I get concerned about somebody who's overly zealous and then injects straight in there. Have I ever had that happen? No. But I don't ever want to see a problem like that. Now you're on the palate. What's the likelihood of anything bad happening? Not so likely. But what if you have unattached, non-keratinized mucosa around the mandibular area and it moves? You can pull the cheek and you see it move out. Well, I'm thinking, is it going to be safe enough? Is it warranted to ask the patient to use it in an area like that? That's clinical judgment. I'm not saying anybody's wrong in doing it. It falls within your scope, your boundaries. Okay, the scope of your practice. Where's your comfort zone? So I get a little concerned just saying to everybody, go ahead and just use, the water stream everywhere. So again, it's situationally dependent.
I describe these to my patients as a toothbrush, Superfloss, water picks. Any of these things are tools. All they are tools. And what works best in your hands? And how can you manipulate that? Some patients can use certain devices and some can't.
Well, see,
others, they're just a device.
But see, the thing we have to realize, okay, the problem is mildly adhesive. Will that water pick predictably remove it all? Okay, that's my issue. And if you
that's my issue too.
But that's why they minimize the amount of pressure, because this is not a driveway, washer, where you pull up all the grease, because then yes, they could clean it very well, but you will see bone.
Yeah.
Okay? So it'll be
not
clean.
A power washer.
it'll be spotless all the way down. So
hey,
we have limitations. There's a limit.
We're bringing out some great people in this audience today. We have a comment, and I'd like to discuss later in our chat. Although the time is ticking away, Dr. Richard Sullivan made a comment here, and he says, the oral hygiene maintenance really starts in the pre-treatment planning, taking the time to import ideal tooth positions into the scan using virtual implants, abutments, and guide pins to establish the ideal emergence profile for oral hygiene ease. Here,
Yep.
that's
Awesome
right
work.
on the mark.
Love it.
Well
Could not have
stated.
stated it better.
Yeah.
I think we should have had him here, and he
Yeah.
would say the same
What
thing.
what
Fantastic.
what a pleasure that he's giving his time to be with us.
I
I mean,
know.
that's fantastic.
Especially
Awesome.
now, it's almost 9 o'clock in the evening where he is.
Awesome.
We have
Awesome
another
stuff.
question about devices, and actually, if I'm not mistaken, this is POE, I believe. She's asking, is EMS airflow ethanol powder safe enough to use on these types of prostheses? My comment would be it's very similar to anything else. It's something is going to be abrasive. I would be cautious about. No?
Yeah.
Again, like Brian mentioned earlier, it's access to it.
Yeah.
You know, I mean, you might be able to get to some areas, but the most problematic areas where patients really, if they have any attempt at cleaning at all, the areas that let's say you had a safe abrasion, let's say you were using something mild that would be unlikely to pit the ceramic or the components, the titanium or whatever part of the system. Well, it's going to be the same areas pretty much like a toothbrush would get, right? It's the parts that the toothbrush and floss don't get, where I don't know of any little micro tip like these periolays, that can go down a sulcus, that we have those kind of that we have a visual with a little fiber optic camera that we know where we're cleaning. Maybe one day, but I'm not aware of it right now. So all the abrasive system, whatever it is going to be getting to all of it. And at that point, if I'm going to use an abrader, I'll remove it and use a glass bead in my lab. If I'm that worried about it.
Well, I think, as you said, the key here is for like a patient, and Chris, you were saying this too, like we have multiple tools, but I think what ends up happening is a lot of patients will say, well, I want to use the water pick because it's easy. And then what they do is they substitute that for the only thing they use, right? And so it's got to be a combination of some mechanical, and that's where you have to get underneath Superfloss being a great example, right? You need to get mechanically in there and kind of scrub the surface, and then you can flush and wash out whatever you want, but you can't have one be a substitute for the other. So.
I completely agree, and I want to kind of take this discussion and kind of move it forward a little bit and talk about yearly examinations. What you guys are doing? How often are you checking the occlusion? What are you looking for? Let's talk about radiographs. Let me look at the slides again, because this patient came in, and this patient is 7 years post-insertion. 7 years. He just came in 2 days ago, so I can evaluate him and do his yearly examination. And this is the way he looks before. But look, guys, what he looked like before I placed this restoration in. Do you think he has any hygiene?
Well, listen, he's better than a lot of people I know.
But what are you guys doing? First off, it's a nice transition because we converted him. Look at how well he's maintaining this 7 years, how meticulous he is in his hygiene and his skills. And I really am proud of our hygienists in our office who are, I call them coaches. They're coaching our patients to do this and working with them. Brian, what are you doing in your yearly examinations? What routinely? What's the steps? So are you taking radiographs? What kind of radiographs? What are you doing?
Yeah, so always, first thing I'm doing is I'm always cleaning underneath, right? I'm always, like I do it multiple times, I'm always wanting to see how well they're doing so I can kind of instruct them on, hey, you did really well here, but we need to improve here, or we need to improve everything, or you're doing great, whatever the scenario is. So that's one thing. Then I do PAs. I think panoramic doesn't really help a whole lot because you get so much kind of distortion from it personally. So I do PAs in area, around the implant locations. And then the last part is, again, checking occlusion, because I think that's probably one of the biggest things. Again, it depends on the material, and I'd say you'd see it a lot more with, acrylic resin, hybrid type prosthesis that we probably don't do as much as we used to, but again, we still do some, because you get the wear and all of a sudden they overload the anterior teeth, and then eventually you get the tooth chipping or debonding, whatever the case may be. So occlusion's a big one I think that's commonly missed. And I think those are probably the biggest things. I personally don't probe around implants. I think we already talked about that multiple times. The feasibility of actually doing that's almost impossible. I mean, if you look at the picture on the screen, right? Good luck probing. Maybe you could get a couple
It's
areas,
impossible.
but, so I don't even attempt that. I'm looking at the tissues, obviously, and you can tell
Absolutely.
a lot by looking and palpating and really visually looking. You see a lot from that personally. So,
Well, they used to say the tissue is the issue.
yeah.
It really is. It's the view of the health of the prosthesis is the tissue. Frank?
Yeah, if you ask me what I do, okay, so let's say we made it to the final prosthesis, it's placed. So I have, and okay, this may sound like cookie cutter, but I'll go 3 months for the first recall. Depending who it is, that's general. If I think, if I needed anything shorter than that, if somebody can't make it 3 months, then I feel I'm not, in my eyes, I'm missing the boat somewhere to take them to completion.
Yeah.
Because now what are they going to do? Okay, I can change treatment plans, and I have done this on occasion. It's rare that someone, because of their demands, the amount of lip support they want to get. And Chris, you're talking about, making it so that they can access it for cleaning, but
Yes.
meet all the other requirements that they want. Well, I may be able to do it by a segmented prosthesis. So that means it might be an anterior bar, the posterior is on the framework, and there's some sort of attachment system to lock in the anterior segment, so at least they can get it off clean there and then put it back and keep the lip support. Or I've transitioned them completely to, which has its own issues, I know, no perfect solution, but taking them to a bar with an overdenture.
Sure.
Mm-hmm.
Okay.
Yep.
So I've had to make that hard and have that difficult conversation with somebody for their own benefit. And really, because we've had so much coaching, like you said, Chris, everybody's there to help them along. But if they're not making it, it's not in their best interest to follow that, because everything's going to tank. It's not going to succeed. So basically 3-month recall system until they graduate and we're comfortable that they can go to 6. But you're right. What you both had said about clinical eval, palpate, visual, rarely I probe. You're right, radiographic. Yes, it's a problem because I don't have a standardized positioning device to know exactly what I'm looking at. But you can tell if tissue looks good. Okay.
Absolutely.
If you palpate and you get no exudate, because tissue can look great, but a little palpation and it erupts a bit.
Yep.
And that's where people can get fooled. Oh, but the tissue looks great. There's no inflammation. There's no apparent bleeding. We clean it. Oh, but you'll be surprised. You squeeze and see what comes out. So
I do that, Frank.
keep,
You're absolutely right. Just kind of just push it, just almost massage the
massage
tissue.
it a little.
Just massage it. You can even do it with just a periodontal probe. Just kind of push a little bit and see if there's any exudate coming out.
Yeah, exactly right. And the patient says, "What the heck are you doing?"
Agree.
I'm just giving you an intraoral massage. Don't worry. It's all good. I'm trying to make you feel good for coming here. But at the end of it, at the end of all of this, you're talking about occlusion,
Yeah.
and that one's a big killer. If
Yeah.
anything gets overlooked more than anything else, it's the functional wear. We talk about how there's minimal wear and all that, but believe me, well, forget that
There
term.
is
When somebody
gonna
says,
be
"But
wear.
why should they believe me?" Just look at the proof. Okay, depending on what somebody does, bruxers rarely stop bruxing, and part of my
Yeah.
post-treatment protocol, everybody that has that kind of restoration, I don't even care if it's natural teeth and implant, they get an occlusal guard. I call it the Holy Trinity:
But that's
brush,
also part
floss,
of
guard.
that's also part of the ACP guidelines is for us to have an occlusal night guard on all the
right.
patients. That's
But
one of
ask
the
how
8
many
steps.
people get it. Ask how
Yeah.
many of them actually have it. Okay.
Well, and
then
how many even
use
bring it?
That's
Yeah.
right.
Well,
How
how
many use
many bring it with them, and you
Yeah.
actually get to see if they use
you
it.
use
That's
it.
the other thing.
Here's the cool part. Here's the cool part. We could do it the old-fashioned way, as much as you can predictably mark teeth.
Yeah.
So when you place it, tap, 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 get a couple of pictures.
Yeah.
And then you can catch them very easily because you don't have to use articulating paper, because I will see wear facets.
Oh yeah.
And that's what we need to look for. Don't look at everything how pretty it is. Bend that mirror and look for that reflection from that beautiful flat surface. If it's on natural teeth, because it could be a unilateral restoration, right? And as smooth as zirconia is supposed to be, we know what happens when you characterize it. Now it's just like feldspathic glass. Look at the opposing arch. Look at what happens. And if you don't catch it, mark it.
Yeah.
Because we start out with timing, right? And then as things wear, you get more and more posterior contact. Take a picture, or the software today, these scanning systems, you can actually track occlusal wear.
Track it from that. It's I just go back to the old Frank Salenza studies that describe, once you do a reconstruction, don't think your occlusion is not going to change. It's constantly changing.
It's humbling.
It is. But Frank, what do you think about something that is in a prosthesis that is in zirconia or ceramics versus now you've talked about overdentures and maybe metal and resin prostheses? That's even more so showing more wear in these types of prostheses, no? Do you agree?
In theory, you're correct. Okay, in theory, you're correct. But when I find patients compliant and putting a guard over that surface, I have the traditional, we called hybrid prosthesis,
Yes.
denture
Yeah,
with
yeah.
acrylic.
Yeah.
I have them lasting. I haven't retreaded one in ages, because when a patient understands you paid this much for this, you spent this much time on this.
Yep.
Do you want to risk it by not maintaining yourself at home? And do you want to not maintain and minimize the wear and tear? And of course, I said the other thing I always tell somebody too, and we don't do this always collectively enough: diet coaching. What should they be chewing?
Sure.
Okay. How should they be chewing? I spend so much time on trying to educate people on not doing the pile driver mastication technique. Have you ever been to a party and you see somebody toss a tortilla chip in their mouth and you can hear the crunch across the room? That scares me, because I use the analogy: you're in the same pool, there's a 10-meter platform, or you dive off the springboard. You do a belly flop from the springboard, the most that happens is you're embarrassed, right? You do a belly flop from the 10-meter, it's the same freaking water, but you slap on that, they're calling the EMTs to come and get you, the paramedics. Okay, so it depends on the amount of velocity it takes for somebody to eat. So when they ask me, can I eat nuts? I said, yeah, if you take it real slow, like you pretend every time you bite into a peanut that you're going to break your teeth. Well, that makes me nervous. I said, it should. So you just break it up till you get into little pieces, then go for it. Tortilla chip, no problem. I do it with my teeth. I have cracks in my teeth. Do I want to break a tooth? So I just break up the tortilla chip until it's in smaller pieces, and I don't worry about it. We
So
don't
Frank,
spend enough time to teach people.
so one of the things that they're asking here, a question is, do you use a hard PMMA type night guard, or do you use a soft sports guard? Is that okay? And as we start to wind down this, I have one more comments as we move forward. Maybe you can answer that one quickly, Frank.
Hard.
Hard. Perfect. Hard. No, never put a soft one in. It just makes it chew more.
That's right. It's like gum.
It is. I actually have a patient that was treated by Dr. Yvonne Fortin out of Ontario, Canada. And some of you may know the name. Brian, you know the name. He came up with the concept of the angulated implant treatments, right? And he asked me to, this patient that he treated is with a full zirconia prosthesis, moved to Pasadena. He asked me that we do not scale or instrument around any of the implants or the pontics with the zirconia prosthesis. And he actually, and Rick was so humbly described, made his comments. They've written a couple articles regarding this. What are your thoughts? What?
Absolutely. I don't like to probe, scale, do anything like that. I mean, I'm gonna mechanically clean with something that's nice, like Superfloss, for example, but I'm not gonna go in there with a scaler or ultrasonic or anything.
Absolutely. Absolutely. Yeah. That's such an intimate tissue contact is so important to keep, especially in these zirconia prostheses. It's just critical.
Absolutely.
Frank, any comments? Any last comments there?
I'll play devil's advocate. That's all great when everything's nice and firm in place, adapted well. But what if it's not? What if it is now, you have peri-implant mucositis, okay? What are you going to do? Forget if it's peri-implantitis.
Sure.
But what are you going to do? Something got lodged in there, piece of popcorn shell.
You got to get something out.
Absolutely. What if you actually got calculus down there? As much as we know about surface energy of zirconia, it's great when it comes to almost being like a Teflon surface. It's as close if it's not characterized. Okay.
Exactly.
If it's in its native state, smooth.
Exactly.
But having said that, I have a lot of crowns on teeth that still people collect calculus. It's a hard deposit. I'm not going to Superfloss that out or proxy brush that off. You're going to have to go in with something. And that can bring up, whether you have coated scalers, however you're going to get in there. But there are going to be times we have to touch it.
Sure.
Okay. I wish I could say I never had to, but I've had to. Hygienists have had to. Okay. And I mean, that's kind of the nature, and we have to be prepared for that because it's when times aren't good is when we get challenged.
Can you believe the time is up already, guys?
Wow.
This has been exciting.
You know what? We need to change this time frame. I mean, I know people on the East Coast and globally, it may not be good we run longer, but come on, this is too much fun.
This was an exciting topic. I just nobody talks about it. It needs to be talked about more because this is what's necessary with the success of these types of treatments. They have a huge investment in it. It's so important as the care. It's just like Frank. It's just like how you take care of your cars, and Brian. It's maintenance, right? It's all about maintenance.
It's just like how my wife takes care of me, right?
I don't think so, Frank. Thank you to my two dear friends, Dr. Brian Goodacre, Dr. Frank Vidjak. It's an honor and a privilege to have you both on the show today. Thank you. Thank you. Thank you. Our next episode of Clinical Chats will be on Wednesday, November 8th. And we're going to talk about this. Here's our sneak preview for those who are on and for Frank and Brian to look at. What are we going to do about this patient? This patient came in and asked to treat her? What went wrong? Where do we go? What do we do?
Congratulations.
What happened? What are you guys laughing for?
No, I love it. This is great. I'm looking
good
forward to it.
So watch out for our next clinical chats. That's on Wednesday, December 13th at 5 p.m. Pacific time. Watch out for more information about this patient and what we're going to do. I'd like to wish everyone, can you believe this? Happy Thanksgiving to everyone.
Yeah.
And wish everyone a happy time with their families, and very grateful for both of you joining me on the program here. I just enjoy it just to talk and listen to our conversations here.
Well, likewise. Such a pleasure to be with both of you. Have a great Thanksgiving.
With that, with my utmost enthusiasm, I'd like to extend my heartfelt gratitude to all of you, our beloved fans, our viewers, to creating brilliant smiles that makes the world a brighter place. Stay well, my friends, and until we meet again in December, happy Thanksgiving, everyone. Good night.
Good night.